morning, ladies and gentlemen. I'm Dina Baddar, and I'm happy to be live from WATANY Ophthalmic Summit in Cairo, Egypt. We start off today with Professor Roberto Belluci, who's a professor of ophthalmic surgery practicing in Verona, Italy. He's also former chair of the Italian and the European Societies of Cataract and Refractive Surgery. Good morning, Professor.
Good morning.
We're very happy to have you here in Cairo, and we're happy to talk about a hot topic right now, which is presbyopic IOL correction. So first off, tell me about patient selection. Tell me about the best candidates that you find in your practice for such lenses.
Basically, every patient may be a candidate for presbyopic IOL because when we remove the natural crystalline lens, they are left with difficulties in near vision. However, because of the different type of surgery and because of the cost of this lens, I ask patients if they would think beneficial to remove spectacles for near vision. And if so, I talk with them about presbyopic IOLs, the various options that are there. Practically speaking, however, there are a few categories of patients who may not be ideal candidates. And for instance, those who drive a lot at night, for instance, sky pilots, plane pilots, because the little, I shouldn't say blurring, but the little halo around the light that is common at night with presbyopic IOLs may disturb them. However, I should say that practically more than 90% of my cataract and refractive IOL patients receive a presbyopic IOL.
Wow, that's very interesting because among the available lenses on the market right now, can you tell us the differences between each and every lens?
I think now there are two main categories of presbyopic IOLs. The first one is called the extended depth of focus IOLs. Those are lenses with either a refractive or a diffractive optical pattern that provide 2 diopters of pseudo-accommodation. Those lenses are useful for patients who accept the spectacles for close reading, but patients who want to be independent from spectacles in 80% of their life. Not all of my patients requires close vision. However, many women do because in Italy they sew, for instance, and for them, true presbyopic correcting IOLs are necessary. Those lenses will provide about 3 diopters of pseudo-accommodation, allowing them to read at 30, 35 centimeters, or even smartphones whatsoever. And I think at the moment, the most successful of those lenses are the trifocal lenses. Trifocal concept is difficult to explain because it's not 3 is better than 2. It's just because there is a different type of light refraction, and the transmitted light is exploited in a different way. Practically speaking, 90% of the incoming light is used to provide vision, and this limits the halos, the star bars, the optical disturbances at night, providing the so far best near vision available. I think that trifocal lenses will lead the market of presbyopic IOLs in the close future. Out of them, there is one lens that started this process. Others are coming, and new ideas and concepts have been developed and expressed at latest ECRS meeting in Paris just a couple of weeks ago. We have been overwhelmed with new designs of presbyopic IOLs, and this is because there is a great interest both from surgeons and from the patients in these IOLs.
What are the common causes that you encounter in your practice for those kind of lenses, dissatisfaction after surgery, and how do you tackle those complaints?
Out of the 200 patients I implanted over the recent years with trifocal lenses, I have only 2 patients that are not satisfied with the surgery. One is a patient who cannot read the very small print, the stock exchange quotations in the newspaper. It's smaller than Jaeger 1. And the other patient is a highly myopic patient with low best corrected visual acuity. So that's a reason for me to be cautious in high myopia. All the other patients are satisfied. However, a few of them required a second procedure. A second procedure was required for the post-operative small refractive surprise, and this was 10 patients only out of those 200, so 5%. One of them is still complaining about night vision disturbances 1 year after surgery. We know that night visual problems, glare, halos, they disappear over 6 months. And 6 months after surgery, our friend Murta in Portugal demonstrated with functional MRI that the brain gets accustomed to the new vision produced by trifocal lenses. So up to now, I have 99% of satisfaction.
So in your experience, what kind of professions are mostly satisfied with the trifocal lenses, and who would you say needs more consultation preoperatively?
All those who work at the desk are pretty satisfied, and those who are very active and may stroll around factories and so on, they're satisfied. Those who work in an open environment, they're pretty satisfied. I would be cautious only with 2 types of professions. Not ophthalmologists, I did surgery on ophthalmologists and surgeons, on engineers, but those who drive a lot at night, like taxi drivers, they probably need a little more consultation before surgery. Also, professional photographers who use eyepieces may not be ideal candidates for these type of lenses. Basically, if they prefer precision, then go for a monofocal.
Okay.
If they accept a small compromise for comfort, then multifocal is appropriate. So far, only a few patients refused the multifocal, and after surgery, they complained about their choice.
Oh,
They would prefer
a
multifocal.
Oh, very interesting. And when the time comes, what lenses are you choosing for yourself?
Trifocal, definitely. They're great, and all my patients are doing great, including the chief nurse of my office.
Wow, wow. So we're very happy to speak to you today. Thank you for being with us, and thank you for your time.
Happy to be in Egypt, and thank you.
Yeah, right.